Today I'm joined by Dr. Tamara Hunter, Perth's leading IVF and fertility doctor. Now, while infertility and couples struggling to conceive is definitely not a new phenomenon, it's thankfully one that more and more people are talking about. But for many, IVF, although a term we've heard of, it remains a bit of a mystery as to what it actually means. What's actually involved from your first doctor's appointment to having a baby? And what are the chances of success? How much does it cost? And why is it so stressful? When is the right time to freeze your eggs? And what about sperm donors? Dr. Tamara is a wealth of knowledge, and I had so many great questions that she answered so generously. You are going to love this episode. Let's get into it. Tamara, welcome to the podcast. I really appreciate you coming on.
My pleasure. It's lovely to be here.
So tell me a little bit about you. What is a fertility doctor?
Well, I actually did obstetrics and gynecology. That was what I trained for. And then about 4 years through my training, got completely burned out and realised that getting up at 3 o'clock in the morning and delivering babies just was not for me. And I discovered that there is this really amazing area, subspecialty area, called reproductive endocrinology and infertility. So I went and did subspecialty training after obstetrics and gynecology in this space. And so I've worked in this space now for 14 odd years. I work predominantly in fertility, but I actually do all reproductive endocrinology. So I do pediatric adolescent gynecology and menopause. So everything from cradle to sunset. So it's a fun area. I get to dabble in male health all over again, work in the fertility preservation, oncofertility and recurrent miscarriage space as well. So it's a really inspiring, uplifting, challenging space to be in.
Yeah, I can imagine. So obviously infertility is something that's probably been around forever, but it's always been something of a sort of taboo or unspoken about thing that many people have had to sort of endure. And I think that taboo is definitely being broken down and people are probably being a little more open about it nowadays. But when should people be concerned if they're not falling pregnant?
Well, it depends on the age of the woman, unfortunately. We were born with all the eggs we were ever going to have. I know you know this. And our quality and our quantity goes down as we get older. Guys, we don't care so much about their sperm quality until they hit about 45, but certainly women start to drift down in quality and quantity after the age of 30. So we arbitrarily suggest that if a couple who are trying to conceive and they're under 35 years of age have not conceived after 12 months of trying, they should probably seek assistance. And over the age of 35 for the woman, if they've been trying for about 6 months and haven't conceived, they should seek assistance. And the only reason that's a shorter period of time is because of that age factor.
Okay, all right. And in terms of, when you would be, what would be the next step that they should go along after they tried for 6 months or 12 months, depending on their age, what should they do next?
Yeah. So I'd always recommend that I think females are quite motivated in this space to understand their cycles, and there are lots of cycle apps out there. I would highly encourage young women to start using them early and just get awareness around their body and their cycle. So once they've done that, I would always suggest going and seeing a GP who understands fertility, because they will start to institute some of the important investigations that need to be done. So are you actually ovulating every month? They can do a mid-luteal progesterone level. Are your tubes open? They could do an assessment of tubal patency. They could encourage your partner to go and have a semen analysis, given that 30% of infertility is male-related. And they can optimize all of those lifestyle things that often kind of stump me. They come to my door after 12 months of trying to conceive and they might still be drinking a lot of alcohol or still smoking, or perhaps they've had trouble with weight management. All of those things I think can be addressed and should be addressed with the primary practitioner. So I think seeing a GP who understands the fertility space as the first port of call, get those initial investigations done, see if there's anything that can be tweaked around lifestyle, and then come and see a fertility specialist.
And so, Tamara, obviously as a GP, I sometimes feel like patients feel like we always talk about their alcohol intake and whether they smoke or not, and, you know, whether they're overweight. But are there clear connections between those things and infertility?
So from the alcohol perspective, it's really about the pregnancy. So the data is around the fact that we don't know if there is a lower limit of safety. So we would just rather you not be drinking in pregnancy. Alcohol is a toxin, and sadly, it is part of our culture here in Australia. And I say sadly only because we really struggle to get those standard size drinks. We struggle to understand them. So a lot of people will come in and they'll say, oh, yeah, I have about 2 to 3 standard drinks. And when you're measuring it, all of a sudden they're actually up to 6 drinks a night. Guys particularly are very good at saving them all up until Saturday night and having them all on Saturday night, which, like sperm, just do not like alcohol. So I do think that there is that role to talk about it as a toxin, particularly in the context of sperm health. Smoking is just a no-brainer. Like, there is really good data to show that women who are partnered with men who smoke, nicotinic residue can be found within their follicles surrounding their eggs.
Wow.
So cigarettes are just all bad. Vaping, we have no data, so better to stay away from it. There is also the the longitudinal nurses health study showed us that a Mediterranean-style diet is probably more associated with fertility and pregnancy than any other type of eating. So again, it sounds really boringly obvious, but getting those things right does make a difference.
And where do you stand on supplements to improve fertility?
So it's a hard one, isn't it? Because sometimes we feel like we have to take something that it's going to improve it. The only one with any appreciable amount of evidence is folic acid. There's data from 30 years ago now, even longer, 40 years ago, showing that having at least 500 micrograms of folic acid supplemented into the diet is really important to reduce the chances of neurotube defects. The other one that over the last couple of decades has become really important is iodine. We know we have iodine deficient soils, so having a supplement with iodine in it is important. All the other stuff is a little bit fluffy. So there is a little bit of work being done in the vitamin D space, particularly at the level of the endometrium. So I would ensure that a patient is vitamin D replete. About 1 in 3 women is vitamin D deficient at the end of winter. So it's worth measuring. And iron deficiency, well, most women become iron deficient anemic during pregnancy. So ensuring that replete with iron as well is important. Everything else, I think if you are observing a really good diet, you can get everything else you need.
Okay, awesome. So Tamara, most people have heard of IVF, and most people, I think, probably think of it as being quite a stressful process that they've maybe seen a family member or friend go through. But what actually is it? I know it used to be called test tube babies back in the day. But what actually is the process?
Yeah, Shauna, I say to all of my patients, it will be the most socially, emotionally, financially, physically burdensome thing that you'll probably ever do. And there's a lot of parallels with treatment for cancer, to be honest. It is a really grueling process. So generally an IVF cycle will mirror a woman's menstrual cycle. There's a couple of different parts to it. The first part is what we call hyperstimulation of the ovaries. So every month, a woman will produce a group of eggs. And from that group, one of those follicles will grow big and get ovulated off. The rest of them just die. So really, as a reproductive species, we are very wasteful of our eggs.
I think I read somewhere recently it was 10,000 eggs per cycle. Is that right?
Would not surprise me if that is the program's cell death. But when we measure ultrasound, there's a group of follicles that grow through together. So in in the first part of the IVF cycle, we just want to stimulate to collect those follicles. They all start at about 0.5 centimetre, and using hormones, we want them to grow up to about 2 centimetres each. So an ovary will start at about that size, and it'll end up at about that size. A woman will feel very bloated, and she'll feel very hormonal because we're pushing the estrogen levels really high. So she rings up on the first day of her period. She's already been furnished with the medications at home. Unfortunately, thus far, we've only got them in injection form. We don't have them in tablet form, but that's something many research institutes are working on. So from that point, she starts a daily injection in just under the skin, often into her belly. There's a ton of YouTube videos and Instagram posts that you can see of women giving themselves their injections. And we're monitoring the growth of those follicles with blood tests and ultrasounds. After about 2 weeks, when the ovaries are about this size, she will then get another injection called a trigger injection. And what this does is mature the eggs within those follicles. We only want mature eggs collected. 2 days after that trigger injection, she then goes in for a surgical egg collection. Now, in most places, she'll be put off to sleep. Some they do it under sedation. Some they even do it like with a little bit of a dazzler. And she'll, I know, right? And so she'll have a transvaginal ultrasound passed into the vagina with a needle on the side of it. Now, those ovaries are so big and heavy, they've fallen down into the pelvis. They're really easy to access. And so we're watching ourselves with an ultrasound. We pass a needle into a follicle and we suck out the fluid, and the egg comes with it. It travels down a little tube into a test tube. And that test tube we hand over to our embryologist, and they look under their microscope and they go, "Yay, Tamara, you've got an egg here. Fabulous." We move on to the next follicle, and we harvest all the ones we can see on the left side and then all the ones we can see on the right side. And we're hoping for somewhere between 8 and 10 mature eggs collected. Those eggs then come back to the laboratory. Now, hopefully the gentleman has given us a sperm sample on the day. Fresh is best. We like fresh sperm. And at that point, that's when we do the IVF. So IVF is actually where you put an egg in a petri dish, you surround it with about 100,000 sperm, and the best one wins. And we do it to every egg that we have collected from her. So we're giving her multiple opportunities to create potentially multiple embryos to give her more than one opportunity to have an embryo transfer.
And are you doing anything at that stage, selecting specific sperm or anything like that?
Yeah, so this is where you can get into the nitty-gritty, and embryologists love this because there's so many tools of the trade that they can use. But there are techniques to select sperm, like better quality sperm, based on lots of different parameters. It might be how it looks under the microscope. Often, though, in IVF itself, we kind of let the egg and the sperm choose each other, that natural selection process. Those fertilized embryos go into an incubator, and that incubator replicates what's happening within the tube. It's amazing, sort of the right temperature, the right oxygen, the right nutrients, and those embryos are just allowed to grow, and all the cells compound. So 2 cells to 4 cells to 8 cells, 16, so on, all the way up to about 100 cells on day 5. At day 5, we take them out of the incubator and we look at them under the microscope. And at that point, we choose the prettiest looking one. We have a special grading system that all embryos are trained in. And that pretty looking embryo is transferred back into the uterus 5 days after the egg. Why day 5? Well, that's actually the day that the embryo would have arrived in the cavity down the tube. So the endometrium is ready to receive that embryo.
Okay, so I've got a question. Obviously, we're Australian, based in Australia, but we've got listeners worldwide. So in Australia, what are the rules around how many embryos that you can transfer?
Great question. We're very proud in Australia to have amongst the best single embryo transfer rates in the world. In fact, my mentors pioneered the concept of single embryo transfer is best for the one. Multiple pregnancies have risks risks of preterm birth, risks to the mum, risks to the babies. And so we want to promote the health of the child. So we want a woman to have a single-term healthy baby. That's what we want. And so single embryo transfer is the way to do that. Does it mean you can't have a double? No, it doesn't. But our preference is to do single embryo transfer, and our rates of success are as good as anywhere in the world with single embryo transfer.
Okay, that's really interesting, because I think there's been a lot of celebrities who've had twins. So I think it's made having twins, I don't know, popularized and perhaps made to be, but I think as a doctor, if anyone's ever worked in a special care baby unit and you see lots of little preterm twins and triplets, you realize that it's actually very, very stressful.
Oh yeah, in the US, higher order pregnancies, so twins, triplets, quads is pretty routine in IVF. I think it's somewhere like 35% of ART pregnancies. But you're right, with that comes cerebral palsy rates, cesarean delivery rates. So the health burden is actually much higher, not only for the families, but also for the health system.
I know it's only going to be an average number, but how much does it cost to have a cycle of IVF in Australia, or is it very variable?
Yeah, so this is interesting. There's a lot of mythology, I think, out there about how much IVF actually costs the individual. It's in the ballpark of 10,000. And I say that plus or minus because there's various levels of treatment that you can get. But here's the amazing thing in Australia, 70% of that is covered by Medicare. So if you've got private health, it will cover your hospital visit when you go and have your egg collection. Many people are out of pocket, maybe $2,000 or $3,000. So it is relatively, compared to what other countries in the world spend on assisted reproduction, we have a fantastic system here that supports us.
And is there a limit to how many cycles you're allowed to have supported by Medicare?
That is such a great and loaded question, because we debate this within our industry all of the time, because you would think, right, that we would want to limit it. But right now, there are no limits in Australia as to how many Medicare-funded cycles you can have, which begs the question, are we necessarily spending the Medicare dollars correctly? And we do debate this all the time. Should we be allowing women of advanced reproductive age to have in excess of 6 cycles when we know their chances of success are less than 1 in 200?
So that actually was going to be my next question. What is the chance of success? I know it does vary with age, but can you give me a little idea of numbers?
Yeah. So it definitely varies with age, and there's a wonderful website that has been generated by ANZARD, which is our Australian New Zealand assisted reproduction database, called yourivfsuccess.com. And on there, you can plug in your numbers. So you can plug in your age of your partner, if you've had any previous treatment, what potential pathology you might have, like endometriosis, and it will pop out your chance of success with IVF. Ballpark, and it depends on the quality of the lab, the age of the woman, any other pathology she might have, but ballpark, a woman in her late 30s probably has about a 35 to maybe 40% chance of a positive pregnancy test when she transfers an embryo.
What then is the chance of that still being a pregnancy at 12 weeks?
Well, that's exactly right. It does drop down. So you've got a miscarriage rate in there.
Sorry.
Hard to say. Yeah, I know. It's hard to pick out numbers. I want to say that live birth rates sit about 20 to 30%, perhaps high. Again, there's so many confounders in there, which is why I find it's a very difficult thing to generalize. It's often a conversation had with an individual couple, because everyone's journey is just slightly different.
I know you spoke about this right at the beginning, and certainly my experience, both as a GP and as a friend, watching people go on this journey. I have watched relationships break down. I've watched people become really quite depressed by the whole experience. And I'd love you to speak to a little bit about what you witness on those journeys and how perhaps people think of it in quite a flippant way, but it really is, it's quite arduous, isn't it, on people's emotional and mental health?
Oh, Shauna, it is. I don't think you can get through this unscathed in some way. I don't have a patient ever walk into my office and say, "Oh, Tamara, that was fabulous. Let's do it again," ever. The longer you go through this, I sometimes talk about it like an onion. Every time you take off a layer, something else makes you cry, because often this is a process of revealing new thing after new thing. Doing an IVF cycle can be as diagnostic for someone about their health and well-being and their chance of success as it is therapeutic. There's a beautiful longitudinal study done through ANZARD again that shows a woman, they actually tracked a woman over 10 years, whatever sort of fertility centre she went to. And what they found is after each negative pregnancy test, 1 in 4 couples will drop out of treatment. And the main reason given is the psychosocial burden, not the number of needles, not the operations, not the blood tests, but the psychosocial burden of treatment. So the one piece of advice that I will always give my patients is please make sure that you have some psychosocial support, whether it be formal support with a psychologist or just making sure that you share on a support group or around your family. Don't try and do this by yourself.
How many IVF cycles is too many?
Oh, gosh. I had this, and I don't know why I have this number in my head, but I had this magic number of 6. I think within 6 fresh stimulated cycles, you can kind of tell what the likelihood is of somebody's success. And when I say 6, that's 6 where you do some investigations along the way. You might find something else, or maybe they have endometriosis along the way, so you treat their endometriosis and then you do another cycle. But I find that by the time someone has gotten to 6 cycles, they're kind of spent. And if I've done my job well, I should have exhausted everything by then.
Yeah, absolutely. And do you feel that whenever people are maybe having more and more cycles, you're watching your patients in front of you sort of disappearing emotionally and mentally?
I remember at the beginning of my career, maybe 2 years in, I had this beautiful lady who put 2 years into banking embryos because she wanted to test them for a certain gene condition. She spent 2 years, so that's a cycle every second month, to bank embryos so that she could test them. And when she finally tested them, they were all affected by this particular gene mutation. And she turned around to me and she said, "Tamara, I'm 42. I've spent the last several years of my life doing this, and my son is 6 and I've missed 4 years of his life. That's it. I'm done." I'm like, good reason.
Yeah, absolutely. It just, it takes such a toll on people. So obviously, Tamara, we're both in medicine, but not only in medicine, lots of women who have professional careers or for various reasons seem to be postponing motherhood. And it seems that people sometimes are finding it harder and harder to find a partner. And I'm definitely seeing more patients coming in to chat to me who are maybe early 30s. They haven't found a partner and they're beginning to panic. They're beginning to panic that they maybe should be thinking about freezing their eggs or what should they be doing. And I even know of a couple of medical colleagues who got to probably late 30s when they really thought about it, and rightly or wrongly, they were told that they'd probably just left it a bit too late. So I'd love you to talk a little bit about that and the timing of that and why people are going down that path a little bit more.
I think the first thing is to understand that it's only been in the last 10 years, maybe even less, that the concept of freezing your eggs has become scientifically robust. Prior to that, it was always deemed really experimental. So we finally have this technique that allows us to literally preserve our fertility in time. As we discussed at the beginning, we do have this biological clock, so to speak, that our quality and quantity goes down with age. And so we are able to preserve, say, a 33-year-old egg, so that if we were to finally find Mr. Wonderful or get that career or whatever, and we come back and we want to have a chance of a family at, say, 39, we can use those 33-year-old eggs and the pregnancy rates will be better. So that's the kind of theory behind it. Unfortunately, we don't have a lot of good quality Australian data on this. So most of the data that we have around egg freezing is international. And that's based on egg donors. It's based on women freezing for prior to cancer, electively. Like, it's quite a mixed bag of women. But what they say in this data is if you're 35 years or under and you freeze 15 good quality mature eggs, you have a probability of a live birth of about 80%. One live birth. Some data coming out of South Australia has shown us that each egg frozen has about a 5% chance of a baby. I know. We are not a very good reproductive species.
Yeah, that is low, isn't it? So 95% don't work.
So each egg has a 5% chance of a live birth. So you would need to freeze 15 or more. And the older that you get, the more you've got to freeze. So if you're over 35, you probably need to freeze about 20. And quite frankly, if you come to me at 38, I'm probably going to encourage you to get a sperm donor and not bother freezing your eggs, because I just can't give you any guarantee of success. So it sounded like the Holy Grail, but I'm just not convinced that it's the be all and the end all, because there's so many other things about fertility apart from age that are important to consider. All this does is overcome age.
And so does that mean that basically eggs don't freeze as well as embryos?
Everybody asks me that question, and it's such a good one. It's kind of like trying to compare apples and pears. We're freezing the gamete when it's one cell, and it's a big cell and it's got lots of fluids. So there's big fluid shifts when you dehydrate it and plunge it into dry ice. So that's one thing. The other thing is when you've got an embryo, it's already kind of proven itself a little bit. It's proven that it fertilizes. It's proven that it's gotten all the way to day 5. And then these cells are so much tinier. There's not much fluid shift. So the cells do better with the plunging into dry ice. So yes, embryos do freeze better than eggs. But when you're 33 and single, you kind of don't really have a choice.
Yeah, absolutely. And so basically the embryo has already self-selected itself to be better, really. Okay. And I suppose that gets me to sperm donation. I've had quite a few patients coming in and talking about the Netflix documentary. I don't know if you've seen it. I'm sure you have. The Man with 1,000 Children, I think it's called. What did you think of that? I thought it was horrific.
Yep. Very scary stuff. Minefield, I think, is the way that
Do you think it's the tip of the iceberg? Like, do you think the reality is that he's not a lone wolf and there's probably lots more?
I'm going to talk to WA because I know the WA market, and then I'll kind of talk a little wider and talk Australia before I talk local. So here in WA, we're somewhat protected by our laws. Many people call it quite conservative, and it is very frustrating for women over here who wait on donor lists for like 2 years to get a sperm donor. And many of them just age out. And that's a real problem. But what we have is a very strict protection of our donor recipients and our donor conceived children, that you can only donate to 5 families outside of your own, and that's globally. So by having just local donors, locally recruited donors and known donors, we're able to adhere to that somewhat. When you start to then look at Australia as a whole, increasingly we are accessing these large sperm donation and egg donation banks that are international. They recruit from a whole heap of places. So Eastern Bloc countries, Ukraine, Georgia, for example, depends on where the company was set up, Europe perhaps, America perhaps. And although they do state that the particular donors they make available to Australia are definitely altruistic. And for example, WA, they're limited to 5 families only, and no, they won't share photos, adult photos. How do you police that on a global level? I don't know. We don't have a national registry for donors. It's a state-by-state legislation. So all I can say to my donors who come in for medical review, please understand you're bound by West Australian regulations and you can only donate to 5 families, including your own, and what that means. And they sign a bit of paper. But can I determine what they do over in Europe? Well, no, not at all. So I think it is really important that shows like this are there for people to consider. Do I think this is a problem that's easily solvable? No, I don't. But I think that women they need to understand what they're actually getting into.
And so are sperm donors paid?
Not in Australia. So legally, it has to be altruistic. All donation has to be altruistic. Surrogacy has to be altruistic. Because you can understand there'd be that exploitation potential.
Such an interesting concept of the whole thing. An egg donation, how does that come about in Australia? Is that something that maybe people who've already gone through IVF maybe donate eggs, or what way does that work?
Yeah, again, we are bound by state legislation. So every state has different rules and regulations. But again, it has to be altruistic. So you've got to think to yourself, what sort of amazing woman would put herself through the equivalent of an IVF cycle for someone else that she doesn't even know? So it's quite an amazing concept. So you can imagine that egg donors are few and far between in Australia. Again, it is altruistic donations, so they're not paid for this in any way. Of course, many clinics or recipients will actually pay for the cost of the cycle, and it's not Medicare rebatable because that person does not have infertility. So it is an expensive process for someone to go through. And yeah, getting egg donors is really hard.
Tamara, what about, do you look after many women who are having to have a kind of speedy cycle of IVF because they're maybe about to embark on treatment for cancers?
Yeah. I will forever be grateful to my patient having fertility treatment prior to breast cancer because she was the whole reason I found my breast cancer. But I do see a lot of patients who have to have rapid cycles of either egg storage or embryo storage prior to starting the cancer treatment. The most common group is the breast cancer population because it's such a prevalent cancer, and it's also prevalent within that reproductive age span. Even men as well, due to commence chemotherapy for anything sort of from hematologenous cancers right through to testicular cancer, are encouraged to freeze their sperm as well for the small risk that they may not have spermatogenesis occur after they've finished treatment.
I know there've been a couple of high-profile cases in Australia where there was babies born after the death of a father. Well, what do you know what the regulation is around that?
Yeah, well, yeah, yes, I do. Here in Western Australia, we can posthumously collect sperm.
So meaning after the death?
Yep. So sperm can be found viable up to 3 days, 72 hours. Obviously, the further you get from death, the less likely you to find viable sperm. But you can't use it. So currently here in Western Australia, it is illegal to use tissue posthumously. And the really difficult thing is we can't export it somewhere where they...
So are people harvesting in the hope that the law changes?
And we do think the law will change here. Every state is different. Queensland, fairly lawless. I probably shouldn't have said that out loud, but they don't have as stringent rules as we do over here in WA, so they're allowed to do a lot more of that. And again, each state has different jurisdictions around this, but it's a really difficult and very emotionally charged space. And, we do hope things will change soon.
I want to change tack a little bit up with another thing that I'm seeing a lot of younger men, I suppose, coming in talking about checking testosterone levels, wanting to take testosterone. I think there's been a lot of chat potentially online or podcasts, and lots of people wanting to take extra testosterone or taking a testosterone not prescribed by their GP. And I do think that a lot of men don't realize that this is actually going to impact their fertility. I would love you to explain why that is such a problem.
Oh my goodness, Shauna. I had a patient just like this week. You must have been sitting in the corner of my office. So you're absolutely right. Taking exogenous testosterone will shut off sperm production. That's the long and the short of it. A lot of men go to different practitioners with issues with fatigue, vitality, tiredness, low libido. And as you know, they are very complex constructs. There's so many things that can lead to fatigue, low libido, stress, a whole lot. But then they get a testosterone level done, and if you don't do it at the right time of day, it will be low. It's supposed to have this diurnal variation. So they get a testosterone level, and the doctor says, great, we'll just give you some testosterone and that will boost your libido and your vitality. And it does. They feel better. But that exogenous testosterone then feeds back to the brain and acts almost like a contraceptive. It's a male contraception. And it will turn off the brain's signal into the testes in two ways. Firstly, it turns off the FSH, follicle stimulating hormone, so sperm production stops. And then secondly, it turns off the LH, which is responsible for testosterone. So their own natural testosterone goes down. So here's the problem. They can't get off the testosterone because the moment they stop it, they feel terrible. They can't get out of bed. They have no libido. So it's a nasty, horrible spiral that they get on, and it's very difficult to then reverse the treatment. And it takes a long time for sperm production to come back.
Oh, what kind of period of time? I did tell someone, because I looked this up a few weeks ago, because I had actually two patients in quite quick succession. And obviously it's being talked about a lot. And I did tell them it could take up to a year for their sperm to come back. Is that right?
Absolutely. And it depends too on how long they've been on. So if they've shut that system down for a long period of time, it's going to take months to years, potentially 2 years, for that sperm production to kick back up to normal. Probably months with regards to the testosterone. So we can use recombinant HCG in place of LH to start that testosterone going again. And we can give them FSH as well. So we can kind of start to promote that, and it'll happen in a slightly shorter time, but still months.
I mean, maybe you may or may not know the answer to this question, but lots of guys seem to use steroids at the gym as well. That seems to be another big thing. Does that have an impact on fertility?
100%. And the worst thing is that they don't tell you. They come into their appointment and you kind of just have to look at their mesomorphic body shape and go, using the roids, a little bit of decadurabolin going into the mix every day. It's, you have to ask the question because they won't tell you, because they won't realise its impact.
Yeah, absolutely. I think there's a lot of people out there taking things and they genuinely have no idea just the impact that it's going to have. Tamara, is there anything that you wish people knew about infertility or IVF that you just find that you're either dispelling the same myths over and over again, or that things that people have really got wrong?
Shauna, I just was part of a big symposium in the Netherlands recently where we were talking about this concept of how we can improve worldwide fertility, because worldwide total fertility rates are on the decline. In some countries, drastically, they can't even replace their population levels. And I think we're very good at the contraceptive chat with young people. We need to get better at talking about the family building chat, that we're not going to make them all go and have teenage pregnancies, but it is really imperative because it's not that easy to conceive. And the older we get, I'm constantly surprised when I quiz my patients, so what do you think your chance of success with IVF is? And they're like, oh yeah, 50-50. And I'm like, you got about a 15% chance at sort of 41 of actually having success with an IVF cycle. And they're like, are you kidding? So that's one thing, is that I think we need to get better at talking family building when they're younger. The second thing is this AMH. A lot of people come into me with their AMH panicking, thinking that that's it, their life is over. AMH is not a measure of fertility. It's just a measure of their egg reserve and their fertility and their reproductive potential. So I think that's an important message to get out to young people too. Do your AMH for sure, but understand what it means and make sure you're willing to act on the result when you get it.
And do we know why? I did read recently about Japan's falling fertility rates. Do we know why? I mean, are we talking microplastics? Are we talking pollution? Like, what do we know what is going on and why fertility rates continue to decrease?
There are so many reasons. There's so many. There's your social reasons. So, increased economic, financial success, parents wanting to invest in their children, so both of them going back to work so they'd have smaller families, economic pressures, healthcare pressures, childcare costs, and then there's all the biological things as well. So even empowerment of women, right? So in countries where women are now empowered to take contraception, they're now empowered to go into the workforce. All of those things have led to smaller families. And then you've got the biological things. So overall, an increasing obesity rate that affects both male and female fertility. Probably exposures to endocrine disruptors, particularly male exposures. We know there's this reducing sperm counts, and we think that's largely due to exposures to endocrine disruptors and other toxins and chemicals. So it's kind of a combination of a lot of things.
So the reducing sperm counts in men is a real thing and not just a newspaper headline?
No, it's a real thing. Something that I think is a really interesting education point for men is that sperm is a great barometer for a guy's health. So if he's got poor health, he'll have poor sperm quality.
Yeah, okay. That's, very, very true. So, Tamara, I'd love just to finish off by explaining, it's in ways a simple concept, but a tricky concept for lots of people. When actually are they most fertile to naturally conceive? Because there seems to be lots of confusion. And I know obviously at medical school, we're taught how to work that out. But for, average person, that can feel really tricky. People are buying ovulation sticks. They're doing ovulation trackers. Like, what can they do?
I think that using an app when you're young to get awareness of your cycles, understand perhaps the subtle changes in things like mucus, premenstrual symptoms, all of those sorts of things. But data actually shows us for falling pregnant, apps aren't very good. They're not very accurate because they are reflective of what's happened in the past. They don't predict what's happening in your future cycles. I do think that ovulation testing kits in the initial instance for most people is really helpful. So for women that have regular cycles, they don't really have any symptoms, they can't really tell, I do think that using an ovulation testing kit is helpful to time intercourse. There are some populations like women with PCOS that because their LH is chronically quite high, it doesn't register very well. So for them, I would recommend that they do full cycle tracking using blood tests to actually give you a picture of what's happening with cycles. So that's kind of how I would progress. And as far as timing intercourse, there's some really old research that shows if you have regular sexual intercourse every week versus timing it around ovulation, your pregnancy rates are probably going to be the same. So I don't think you need to time it down to the minute, but I think if you have unprotected sex around the time of ovulation, perhaps the day before and maybe the day after, the day of, you're going to get it.
Okay, awesome. Tamara, my second last question. I had a patient recently told me that whenever she was having IVF, she was told that she didn't have great egg reserve and that she was most likely to have an early menopause. Is that a thing that you see?
Yeah. So when we discovered the anti-Müllerian hormone was a really good predictor of ovarian reserve, we also realized it's actually quite a good predictor of when someone will become menopausal. And you do routinely see that women who have an unexpectedly low ovarian reserve for their age, or a low AMH or antral follicle count, they will often have an earlier menopause. So it is, I think, a good representation, particularly, for example, women who might have premature ovarian insufficiency. So that's when they go into a premature menopause before 40. I do think that it's a really valuable indicator earlier in life, so that we can institute the appropriate therapies and investigations for. So it's a really good marker for other things aside from just fertility.
Yeah, I have to say I've started doing AMHs in the last couple of years and find it pretty helpful. It's definitely a really interesting, and it's great now that it's not so expensive. Final question. If you could tell your 20-something self some advice, what would you tell Tamara?
Believe in yourself. I think, like most women, through most of my career, have had imposter syndrome. And I think that it's probably inhibited me from doing a lot of things much earlier in my life. Well, certainly I've wasted a lot of energy ruminating about things. So I would tell myself, believe in yourself. You know what you're doing.
I think they give us a dose of imposter syndrome along with our medical degree.
I think you're right.
Thank you so much. You've been so generous with your knowledge. I really appreciate it.
My pleasure. Thanks for having me.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.